So 5 organisations from the Wales Cancer Partnership have come together today to answer some of your questions and talk a little bit about the work being done to treat and care for people affected by cancer in Wales. So to kick off, I'm going to ask our lovely panel here to all introduce themselves.
I'm Wayne John. I'm a cancer patient and a volunteer with Tenovus Cancer Care.
I'm Alan Parker. I'm a reader based at Cardiff University School of Medicine, where I run a research team that is developing viruses that can seek out and destroy cancers.
I'm Kay Wilson. I'm a senior research nurse at Belinda Cancer Centre.
Hi, I'm Neil Rodrigues. I'm a reader at the School of Biosciences at Cardiff University. I run a research programme based in leukemia at the European Cancer Stem Cell Research Institute at the university.
What do you think is the biggest issue affecting cancer researchers and patients in Wales today?
Well, from a patient's point of view, I think it's communication, both pre and post-treatment, and the quality, integrity and consistency of that information. And also need to consider about how it affects patients, both physically and mentally.
From the researcher's point of view, I mean, obviously funding is always an issue. Funding to find those, basic important aspects of cancer biology that will underpin the next generation of therapeutics coming through, and also taking those really promising preclinical observations and moving them through into clinical translation, so taking them into first in human trials. Having the facilities and the funding to do that is a real challenge.
And that's where I suppose my challenge comes into, is getting those novel therapies from a lab like Alan's into real patients and delivering these novel treatments into patients in a timely manner.
From the patient perspective, as we think about projections for the number of people living with cancer over the next decade, that's going to increase drastically. We sort of have to make sure that the infrastructures are there to support patients in patient support groups and actually in the health service. So we have the ability to treat cancer at multiple levels, social, as well as the actual diagnostic and treatment strategies.
You've kind of touched on the communication there between patients, researchers and health professionals. What do you think might be the best way for people to talk about cancer, and do you think there should be more discussion about the subject freely? Kay, you're nodding there. What do you think?
Yeah, I think it needs to be on the tip of our tongues, really. And it's never going to go away to be in an easy conversation. I mean, Wayne, you must have had, a difficult conversation.
Well, I've had the conversation about myself. Obviously, I made the decision about how I was going to deal with it and talk about it. And I went into work and I called everybody together in the office and told them exactly what was wrong with me. And, we need to talk about it openly and freely. Because really, once you've had cancer, it is your everyday life.
And patients, people are living with cancer now. So, you could have a diagnosis 5, 10, 15 years ago now and still be that cancer patient.
Yeah.
Of course, those conversations that you'll be having and Kay, you'll be having too, will help normalise this and help people recognise potentially some of those symptoms that are associated with early cancers. So the more we talk about it, the more it's out there, the more people are going to think, oh God, I've got a bit of bloating around the tummy. Maybe I should go to the doctors about it. So I think the more we talk about it, the more people are going to be detected early.
There is no shame in what you've got. It's just something that's happened to you. It's an illness. It's a disease.
How we as scientists and medics talk about our research to the public as well. And I think that's important too. Not just talking about recognising the symptoms of cancer, but also talking about where's the money going that you're putting into the collection buckets.
Yeah.
How's that being useful in understanding cancer and in developing the new therapies of the future for cancer as well?
You think, Kay, about patients being able to educate themselves about the different types of cancer?
Some people will, read up about their cancer, and some patients will just accept or just take what that doctor has said at that clinic and not look any further. So I think that will always be individual. But I think, thinking of my clinical area, we see a lot of patients now and they'll have the same type of cancer, but they'll have different types of treatment. And I think it's that, whereas years ago, if we were all in a chemotherapy day unit, we might have had the same bag of chemotherapy for treating our bowel cancer. now chances are we would have 4 different drugs, and I think that's where these guys come into it, by developing those drugs, to giving us more options.
We tend to classify cancers based on the organ they arose from, the cell type they arose from, but actually, every single cancer is unique. One person's bowel cancer is very different to another person's bowel cancer because there's all different subset of changes within each of those, and even more complex than that. Even within one person's bowel cancer, there'll be different cells with different changes in them.
Even within a single class of disease like leukemia, for example, you've got many different diseases encompassing that disease, and with all these different changes that happen within that cancer cell, it's very complex, and it's termed tumor heterogeneity, and we're trying to understand tumor heterogeneity and understand how we can target these particular cells, but it's very difficult because essentially you're trying to hit a moving target.
So we're moving now towards a state where we tend to biopsy cancers and look at the genetics of the cancer and work out exactly what is unique about each person's individual cancer and tailor treatments, as Kay said, to that individual patient. And in some ways, the drugs we will develop are based not about the differences, but about the commonalities. The most common things that are different about those cancer types, and try and design drugs or viruses or whatever we're working on to try and take advantage of those weaknesses.
And you've kind of touched there on how much more complicated cancer is than we might think, even within those specific cancer types and even within one particular patient. So for Neil and Alan, this question is for you really. Where do you think we should focus our future efforts to beat cancer?
In the last few years, we've had a very nice development of a particular therapy called immunotherapy, which uses the body's immune system to fight the cancer. And the immunotherapy has come on quite a lot in the last few years, and it is particularly effective and possibly curative for certain types of leukemias. So what I'd like to see is actually more of an effort to see if we can apply this more widely to other blood cancers and also actually to solid tumours.
So I work on viruses, which in some ways is a way of delivering an immunotherapy, if you like. So that is a way of making some tumours that are immunologically cold, that means that the immune system isn't recognising very well, into an immunologically hot tumour type. So that means that the immune system is much then better at fighting back against the cancer. So I think these ways of, yes, we're in an era now where medicine is moving, or cancer medicine is moving towards immunotherapies. And I think we're now looking at how we can get the most out of those immunotherapies moving forwards, and different tips and tricks that we can get for tweaking those for maximum potential and the least side effects, of course.
I think also another important area sort of related to this is trying to target metastasis. So this is a process where the tumour moves from the primary site, so if you have a lung cancer, to other organs within the body. When it starts to spread around the body, it becomes very difficult to treat patients, and often they succumb. So, we think actually that immunotherapy is actually quite effective for late-stage disease, so that would be particularly useful to try and see if it's applicable to blood cancers in late stage, solid tumours in late stage, at this metastatic stage of cancer.
We don't see chemotherapy given very often within a clinical trial setting anymore. And like you said, these immunotherapies, these targeted therapies, are being seen in the standard of care settings. So they're going through the clinical trial into your standard.
And are these treatments more patient friendly? Because I mean, chemotherapy is quite a harsh thing to endure for a lot of people.
There's still side effects. It's a different type of side effect.
Yeah, it's difficult. I mean, it's quite variable from drug to drug and immunotherapy to immunotherapy, and some of them are much harsher than others.
But it comes back to that again. Another tipping point. We think about your immune system is there for a reason. It's to help you get rid of things that your body doesn't recognise, but to keep things that it does. So if you have, the toxicity can be induced such to a point that you're inducing autoimmunity. So you've tipped your balance of the immune system too far the other way, and you start to get autoimmune effects. So your body starts to recognise things that are self and destroy those. So that they tend to be, rather than the drug-induced side effects from chemotherapies, that's the balance you have with immunotherapies. And it's getting those balances right.
We know we're not going to go into eradicate cancer diagnosis anytime soon. So getting that earlier diagnosis is going to be much better. There's going to be a lot more treatment options when you're diagnosed earlier. So patient experience will be, bringing in these new therapies that, we're developing in the lab into the clinical trial setting earlier to then get them as a standard of care. So the immunotherapies we just talked about, it would be ideal not to wait the 10, 15 years for them to come from a lab into standard of care. That would be a much quicker process. So then the patients, the side effects would be, as we just discussed, different but slightly less than chemotherapy. And it, again, is having these access to these novel drugs quicker, and that would be really good for Wales.
And how important was the role of cancer charities in in funding different
Oh,
types
of course. I mean, we all, as research leaders and PIs, rely on charity funding to deliver our research. So it's absolutely critical, and not just in terms of actually helping us to deliver our research programs and putting drugs through from the preclinical into the translational phase, but also in helping us to disseminate our findings and to get the conversation, helping us to disseminate our research across social media, across the media. Absolutely critical.
They've suffered a bad rap in the last few years, and funding has declined from charities, or giving to charities has declined. But it's pivotal for our research. We've only been funded by, we've predominantly been funded by charities, and it's it's essential for the work going forward. I think it will become even more important actually when as government funds are dwindling towards medical research, and certainly in parts of cancer research. So the roles of charities will.
It's not only on the research side, though. I mean, in terms of patient care, there's so much that the charities contribute to that. It would be impossible for the state or the NHS to provide, the types of services that are done in terms of just helping people along with their finances, making sure that they can actually get back and forth for their treatments. Lots of different packages available, and so the side that I'm involved is in with people's emotional issues around a cancer diagnosis, and they can go anywhere right from the moment of diagnosis through to years after treatment. And it's not only the patients, but it's the patients' families and loved ones and carers that actually suffer the impact of the diagnosis as well.
What is each of your most rewarding parts of those jobs that you have?
Being a volunteer and presenting Activate Your Life, there's a key thing that I often talk about, and I talk about back to the days when I worked for a living. I would have certain days where I'd be driving home from work and I'd be having a real good buzz thinking, I really earned my money today. I've done a good job today. And every time I'm driving home from presenting an Activate Your Life course, that's the feeling I get when I'm driving along. I've had a good day today. I've done some good.
I have to admit, I feel very lucky and privileged to be a scientific researcher because there are great moments when you get papers accepted and get grants accepted, but I think they're kind of the end of the process. The real joys come when you find out something that no one has ever known before. When you make a new discovery and you think, oh God. Those moments when the big paper's accepted, they tend to come 6 months, 12 months after you've actually had that moment where you sit down with someone, often a PhD student or a postdoc in the lab, and you look at their data and you think, wow, this is really important, So those moments are kind of what most researchers live for, I think, and we're lucky enough to have those.
I've been lucky enough to be to give the first drug of its kind to a patient in the world.
Wow.
And that was a really successful drug for prostate cancer. And then working with such a really experienced and fantastic research team, clinical team at Velindre, and then meeting the lab guys like we are today. So I'm lucky enough to be sort of coming from the lab right through to the patients, and so I think I've got the luckiest job in the world.
Very rewarding.
It's a profound pleasure to train the next generation of scientists, both scientists and clinicians, because we're winning battles here with cancer, but really to move forward and win the war with cancer, we need that next generation of scientists to be trained up. So it's great to see their development and for them to get excited about their abilities to tackle this profound issue.
And I would encourage you to get in touch with us with any questions you have. So speak to the Wales Cancer Partnership or other organisations if you would like some more information on what we've been speaking about today. So thank you very much.